Welcome to the Behavioral Health Echo Series. My name is Andrea Havler, and I will be helping to facilitate this conversation today. So to all of you, thank you. Thank you for being here. And as always, this session is being recorded for later distribution. In the meantime, please feel free to start adding your names, affiliations, and other information on the chat. This information will be used to confirm your attendance to this class, and especially if you're seeking CMEs today or if you're part of our Be Well Texas provider network. Again, thank you to all of you for being here. If you need captionings for this class, please navigate to the bottom part of your Zoom windows and click on the captioning feature. To some of you who might be new to this class, we want to remind you that this session goes as follows. We will start with a 2025 didactic presentation, and after that, we will move to a brief case discussion. So this is where we would like to hear your opinions, your views, your perspective. So we encourage all of you to participate in the conversation, especially during the case presentation, as I said. And if you want to do so, just raise your hands and we'll get to all of you as much as our time allows it. And of course, for our case presentation, always remember we will not share information that is too particular to the person we are discussing. And I know some of you are providers and behavioral health professionals, and you're all familiar with PHI or personal health information, but we must remind ourselves before each session that we have to protect the identity of the person we are discussing. We're going to start with some introductions. Dr. Dennis Antoine, how are you today?
I'm doing well. It's great to be here. Once again, my name is Dr. Dennis Antoine. I'm coming from Baltimore, where I'm at the Johns Hopkins Baby Medical Center, and I'm director of the Addiction Treatment Services program there and a psychiatrist by training. Looking forward to hearing everyone's comments and input.
Thank you. Didi, how is the weather in California?
We're having our typical summer weather, which means you better have your long pants and sweater on. So we are fogged in. We have a very high pollen count this year too, hence my tons of Kleenex over here. So forgive me, I'll be doing that a lot. And sadly, we already have seen a lot of wildfires. In fact, I just got a notification that we've got an update. I was smelling it last night, kind of late around midnight, 1 o'clock. So I'm very concerned about that. And here we go. But it's still great to be here in Northern California, Bay Area, and looking at my neighbor's cat coming in for a snack. So that's always fun to have them flying around. Thanks.
All right, great. Thank you. And our case presenter, Dana. Would you like to introduce yourself to the group, please? Is Dana here?
Yes, I'm here. Sorry about that. My name is Dana Cardwell. I'm with the Texas Hill Country MHDD, and I will be presenting the case today.
Thank you. Welcome. Thank you for presenting a case with us today. Jasmine.
Hello, everyone. My name is Jasmine Vidal, and I'm the Behavioral Health Echo Program Coordinator. Thank you for joining us today.
Thank you, Jasmine. And of course, Dr. Clarissa Aguilar, our didactic presenter of the day. Welcome, Dr. Aguilar. How are you today?
Hello, everyone. Thank you. Thank you for that welcome. My name is Clarissa Aguilar. I am the Director of Psychology and Training at the Center for Healthcare Services here in San Antonio in Bexar County, where we do integrated primary care, integrated care that is comprehensive for individuals with substance use disorders and mental health diagnoses, along with treatment for intellectual and developmental disabilities as well.
Thank you. Whenever you're ready, we can start sharing your didactics, your presentation.
Okay, great. Let me share.
Sure, take your time.
Okay. Hold on.
We can see it.
Okay, great. So let me go to here.
Presentation mode. Perfect.
Okay. Okay. So hopefully
Right.
that's good. Everybody can
Yes.
see. Okay, great. Today we're going to be discussing interdisciplinary team-based care in substance use disorder services. And I'll be borrowing a lot from our particular model at the center, but hopefully it'll be applicable to everyone. We all work in large teams. These are the disclosures. I have no disclosures. But our objectives today are to define interdisciplinary care and identify some common elements of team-based patient-centered care. I'm also hoping to provide you all with some concrete strategies that you can use inside your teams or as you collaborate across different sectors with different entities that might be helpful to the work that we do. And then talking about and maybe having a discussion and hopefully to invoke some thoughtful reflection for yourselves about some of the conflicts and challenges that might come up when you work in a large team-based setting. I started off this slide talking about integrated care because integrated care is this idea that we are trying to bring together different disciplines, different professional identities to help our patients. Integrated care has gained some momentum from across the nation. And I remember back when I was training, when I heard the word integrated care, what came to mind for me and what we were taught is to think about mental health services together, being offered together with substance use services. And that was kind of the way it was defined. That definition has changed over time. Integrated care now, of course, means mental health and substance use services together, if necessary, but also to include care related to physical health as well. And so that does require many disciplines working together. So over the years, you probably have heard things like a multidisciplinary team. You hear that a lot in the school. There's a multidisciplinary approach to care. That is a very nice approach because it brings lots of different people together and it helps people look at a problem from different perspectives. Does anybody have an idea of what the difference is between multidisciplinary care and interdisciplinary care? You can throw your thoughts into the chat if you like. What might be a difference between multidisciplinary care and interdisciplinary care? I don't know if I see anything yet. So one idea is that in interdisciplinary care, you are trying to synthesize and bring together the perspectives in a way that you are borrowing from each other and learning from each other, and then providing care in that manner. Multidisciplinary care really is where everybody stays in their own lane. People work independently, but do talk to each other, and you're drawing from your own knowledge base. You are looking at the same object from different perspectives. Whereas in interdisciplinary care, we are trying to integrate the knowledge, synthesize the knowledge, and analyze the knowledge together and try to harmonize the knowledge to provide a patient experience where the patient has a great outcome and may not even know the difference between a person providing the care and the other. So there's a lot of synthesis inside the care that's being provided. So there's a kind of a coherent whole in that patient's experience. Transdisciplinary care is also another term that has come up, which really is this idea that we will supersede the disciplines and move towards kind of policy shifts and stakeholder shifts as time goes on. But I really wanted us to focus on interdisciplinary care as you kind of think about this presentation. So one of the reasons why interdisciplinary care is so important is because of the quadruple aim. The quadruple aim is from the Institute for Healthcare Improvement. They recently updated this aim. It used to be the triple aim, where we obviously, really want to improve the experience of the patient, help provide good outcomes for our patients, keep our costs low. And now there is this real attention to making sure our providers and the people providing the service to patients are also feeling taken care of, not burning out, and being able to rely on a network of other professionals and providers to help with outcomes for the patient. So this is another reason why interdisciplinary care is so important. And it's a common element is to think about the quadruple aim in our healthcare settings. This slide is an attempt to try to have us think about all the different variables that are at play when you're in a team-based model. And so here, I don't know if you can tell, what I tried to put in the back was this, you have your organizational culture, the place where you work, versus maybe a culture inside your organization that really focuses on trauma-informed care. I know many of us work from that perspective. But then on top of that, you have the recovery model of care. And then inside of that, at least in our particular agency, we have the medical model of treatment as well. So you have all these different variables that tend to overlap and really do dovetail into one single aim. But at the same time, all these individuals and all these services that the patient gets, which are kind of outlined here on the sides, show you that we are trying to create a shared practice culture between psychiatry, between social work, between counselors, between peer specialists, nursing, psychologists like myself. So there is this real importance of trying to understand what is our goal as we are all working together in all of these different cultural backgrounds. I talk to teams about really trying to come up with a shared mental model of what it means to be patient-centered. And so it's something for you all to think about with your own team. Have you all discussed this as a team? What do we mean when we say patient-centered care? What does that look like for us? Here at the Center for Healthcare Services, this is what it looks like. This is an example of all the different flags we have outside of our exam rooms, because all of these folks may be visiting a patient inside the exam room, which is a medical exam room in primary care, where they might be getting their blood pressure taken, getting blood pressure medication taken care of, but then they might be visited by a psychiatrist. They might be visited by a behavioral health consultant like myself. They might need to be seen by the peer specialist as well. We have a lot of different elements going into this practice culture. And so sometimes it's really important to try to work together with your teammates to create this shared practice culture, but also think about what it might look like from the perspective of the patient. Sometimes a patient can get pretty confused. And this is kind of another visual of the same idea. We've got lots of different disciplines. I know here in our meeting, we probably have a lot of different disciplines represented as well. One of the ways that we try to make sense of this for our patients, before I get to that, I wanted to make sure that everybody understood that with all the different disciplines represented, we do have the Substance Use and Mental Health Service Administration, SAMHSA, actually developed core competencies for individuals that are working on integrated care teams, working in interdisciplinary settings. So I wanted to make sure everybody at least had a look and a snapshot of what all the different domains of core competencies are if you're working in a team-based setting where you're going to be around different disciplines. So, interpersonal communication is absolutely key, and understanding how to do that. We'll be talking a little bit about some skills that you might be able to use to enhance interpersonal communication. Collaboration and teamwork is another, required competency. Learning how to provide screenings, how to do assessments. And some of these competencies might be more emphasized in some particular roles versus others. I've talked with peers that would say, oh, I would never do a screener or an assessment. That's not really my role. And they're right. You know, they might leave that to the clinician to do. But understanding sometimes what that information means is just as key and important, no matter your role. Understanding how to do care planning, care coordination inside of an integrated team is so important in our particular environment. Providing intervention. You know, we have case examples today that we're going to talk about related to different kinds of interventions that have been provided. Taking a cultural competence and understanding how to culturally adapt your language, interventions, and the way that you are interacting with an individual is also very key in a team-based setting. Having a mind toward that systems-oriented practice, like I said, trying to come up with a shared mental model of what it means to work in a large system, working on practice-based learning and quality improvement to improve your workflows around the clinic. And then informatics, as we all know, you know, we are in the digital age of electronic health records and electronic medical records where we have to learn how to navigate these things. So these are all kind of core competencies that SAMHSA has come up with. And I have this reference if anybody is interested. They have a whole book on the core competencies if you're interested. So this is what I was referencing earlier. One of the ways that we help our patients try to understand all the different team members that might be visiting them is that sometimes one of the interventions that we might do in clinic is just helping a patient understand who their care team is. So we have a handout that looks very much like this, and I might have some of these things identified like a care manager, but I often tell the patient, okay, this is you in here, and we're gonna write down who is involved in your care team today and all the different people that are helping you right now at this point in your life. So I will write things down like your care manager is Sylvia. Sylvia is the one that kind of helps you with the food stamps and helps you figure out who to go for housing. Your psychiatric provider is Mr. Geis, and he's going to be prescribing, and I will literally write down maybe some of their medications. The quetiapine that you're being prescribed is by Mr. Geis, and I'll write that because sometimes patients have a very hard time understanding who to go to for what do they need. And I will then fill in, you know, you actually are also seen by one of the consumer benefits officers that's working with you really closely right now. And I'll write, you know, I'll leave this, it's blank here so you can fill that in and then provide it to the patient. And it's something that they take home with them as like, these are all the people that are helping me right now in this particular point in time. And I'll make a difference, you know, make it sure that the patient understands the difference between the psychiatric provider and the primary care provider that they're seeing. And again, I'll write down that this is the provider that gives you your lisinopril and your high cholesterol medications so that a patient understands who to go to for what. Sometimes that can be very confusing in these integrated environments, and providing this kind of map to the patient that they get to take home is really helpful and sometimes very clarifying. So that's kind of one concrete strategy I think could be helpful for folks. Another strategy to try to really help people work together, keep the communication pathways open is an interdisciplinary team meeting. If you work at the Center for Healthcare Services, you know that we do these across our disciplines. So we try to bring psychiatry, substance use, primary care together to talk about some of the issues or more complex concerns that we have for a particular patient. We have a monthly agenda, we have a carved out time, schedules are blocked. We make it a point and we're very intentional about the time so that we are able to have the time to discuss complex issues together. And so not only do we get to talk about patient care, but we also tend to talk about, oh, you know, this has really been a challenge for us. We haven't been able to, this is just an example, like, it's been really hard to get a hold of Medicaid transportation lately. What's going on? We kind of share our resources. It's a great way to help everybody, again, identify the common goal, what it means for us to be patient-centered. It helps us align our thinking. It helps everybody get on the same page, and it helps us share resources as well. I usually, this is a kind of a brief outline of the agenda, try to include something that's educational, just a real brief little nugget or tidbit about a new journal article that came out, a new science, a little tidbit about, the way exercise might be improving depression in some way. I might add something like that in, but it's a really nice way to carve out time for your team to come together. If there's any way that you are able to do this, that would be a great idea. I have an agenda that I can share with you. This is from the American Medical Association Practice Transformation Series. They have a great modules on interdisciplinary teamwork. One of the other things that's like going to be really important, now we're moving into a little bit of the communication modules, is during these, interdisciplinary team meetings, we need to summarize our patients. We have to be able to provide a concise and clear way of going through all of the different issues. One of the ways that you might want to do this is something called Doctor's Map. Maybe y'all have heard of it before, but it's something that we try to do a lot in our clinic when we're trying to update somebody about a particular case. And so we kind of start in this way, and I provided some examples. Doctor's Map is an acronym, right? So D for demographic information, and I typically include diagnoses, but if that's not where you're coming from, then you don't necessarily have to. But at least the demographic information for D, R is the reason for referral, S are the symptoms, and some of the data that you might have. And you can kind of see I outlined what some of the symptoms could be, right? Like suicidal thinking. In our setting, we use the PHQ-9. I know we've talked about that here before, which is a depression questionnaire. And we summarize their score. They got a 24 on the PHQ-9. They scored number 2. That /2, that's our shorthand in our setting for the endorsement on item 9, which is the item on self-injurious thoughts or thoughts of wanting to be dead. So that's, for us, is a little bit of a flag. How motivated the patient is for treatment, thinking about what your assessment is of the patient, and then any plans or what you want to ask the group about, or what you might be recommending. So I like to use this when I need to go talk to a clinician from another discipline. I will summarize the patient this way and say, this is my concern. I'm thinking that he might really need an increase in his medication because of this ongoing increase in symptoms. A lot of times I'm training new psychology students and residents, and they often tell us, I don't know where to start. I know I have a question. I know I have a concern for another clinician, but I don't know what to do. I don't know how to organize this information. And so the Doctor's Map is a nice way of helping you organize information, especially if you need to have this interdisciplinary consult. It can be tough, but most of you probably have a lot of this information at your fingertips and know your patients so well that you could probably go through the Doctor's Map and provide this, maybe even off the top of your head. So it's a nice way of organizing information. Another particular communication tool is called SBAR. And I don't know if anybody has heard of SBAR before, but it's typically used within clinics and kind of during a clinic day, especially if something comes up. You might want to use this particular kind of format to help a patient or to help yourself talk about a patient need. So it's a really nice technique for organizing your information and helping somebody navigate whatever it is that you need. So S stands for situation, like what is going on with the patient. I noticed that the patient looked really confused when they were trying to fill out the paperwork. The background is I went to go ask them what was going on, and they didn't really answer me.
Just shifted the camera up.
And then, oops,
Big bumps you just did.
I think somebody's talking.
I'm sorry.
That's okay.
I'm
Um,
sorry, Dr. Aguilar. Please,
No
please
worries.
continue.
No worries. Then the assessment is, what do I think the problem is? I might say, well, I'm worried that maybe this patient doesn't speak English, but hasn't really felt comfortable enough to say that. I'd like for someone to provide our paperwork in Spanish. Can we do that? And so this is also like a nice format for helping you organize your thoughts within the clinic, within your other team members, talking to each other. I like to use this kind of format in my mind if I'm going to our front desk or somebody that, is just in clinic and we're having to collaborate and figure out what do I need to do next? What needs to happen? And again, it kind of helps you just organize your thinking. One of the ways that I really like to use the S-bar is also teaching it to our patients and helping our patients understand that this is also a good way for them to format or formulate some of their own concerns about their own situation. It's a great way to talk to their doctors. It's a great way to talk to other clinicians. I mean, they don't have to use it, of course, but it's a nice tool to help organize their own thinking as well. So S-bar is something that you can use within teams, talking to each other. And I guess, if everybody wants to think about a situation where you might really need to go, I don't know, talk to somebody or consult with someone about a situation with the patient, this would be a great way to do it and to use it. The next communication tool, which is always really helpful, is to use a check back. Sometimes it's called a repeat back. And it's very simple, but it can really, really help when you're in a clinical setting. And even when you're not in a clinical setting, I often use this with my teenage boys when I'm trying to give them information about, what I want them to do during the day. So I might say something like, okay, Mr. Garcia needs information on the recovery support groups, and he's really worried about housing. Can you talk to his case manager? I might talk to the recovery support specialist on our team about that. And the idea is that if you have established as a team that we're going to use this check back method, the recovery support specialist might say to me, okay, so I'll get Mr. Garcia the flyer on the recovery support groups. I'll track down the case manager's phone number, and we'll give him a call together about the housing concern. And then I confirm that and say, yes, that's right. So it's a very clear and closed loop of communication where I kind of stated what I needed. The receiver of the information repeated all that, and then it was confirmed. And that really adds to clarity. And as you all know, working in a busy setting, when there's lots of things going on, little things can get missed. So this is a great tool for using a check back. You may also kind of use this, again, I use this a lot with patients as well, where I'm explaining something like an intervention, or I'm explaining maybe the goals that we were collaboratively working on. And then I'll say, okay, let me make sure that I explain myself correctly. Can you repeat back to me what I said to make sure that I explained it correctly? And then the patient gets to say whatever it is that they've heard. I do use this quite a bit with patients, and oftentimes I realize, well, I left this key piece out. I need to make sure that I am being more clear. I know that some clinicians feel like it is maybe not the right tactic to use because they feel like it is, I don't want to say like, some people feel like they don't like the power differential that might create to use a check back because they feel like I'm the teacher and you're the student. But I try not to think about it that way, because this really is enhancing communication. And if anybody knows Brene Brown, she always talks about how clarity is kind. This is really about enhancing clarity. It has, it doesn't have to be related to a power differential at all, depending on how you use it and in the method that you deliver it. So I do think that that's a kind of really key piece of helping clarify communication in teams. And, I guess I can say based on our experience in our teams, we have found that using a lot of these strategies are very helpful and kind of can save you a lot of problems going forward. Okay, so how are we on time? Okay, so I just also wanted to make sure that we had a little bit of time to talk about when you're on a team with multiple disciplines, you have multiple hats that you are wearing sometimes, and the importance of role clarity, having boundaries, both as a personal but also as a professional, are really key in a team-based setting. And part of the great things about teams is that you learn a lot from your teammate. I have learned so much from my own primary care providers about medicine, about treatment, but I am not a primary care provider, so I could never, step outside of my role as a psychologist. And sometimes that learning transfer creates role confusion. And so I just wanted to make sure I left you all with a few questions for reflection to ask yourselves as you think about these things. And these might be questions you pose in a team meeting. So for example, if you were able to pull together an interdisciplinary team meeting, you might think about these questions together as a team. If nothing else, you could think about them on your own, but ideally you'd be discussing them perhaps with a supervisor or somebody that is a professional mentor to kind of help you. I'm just going to run through these questions. Sometimes I know like our peers in our team get concerned about the role that they're playing with the patient because they're also in school and they're also learning. And so it's hard to remember all of the different hats that one might wear. Let's see. Yes. So one of the questions is, what professional identities can I honestly own in this moment by virtue of my education, training, and experience? Am I a counselor? Am I a case manager? What is my professional identity in this moment? What is my role in my current organization? What was I hired to do initially, and has that role changed? What is my role with this particular patient, and what is my referral source? Which overlapping roles have the greatest risk of an ethical violation? Those are all things to kind of think about. And how do I distinguish which role I'm engaging in any professional moment? We know that these things come up quite a bit in team-based care. So I just wanted to make sure you had some questions to kind of think about and to give yourself to reflect on. So thinking about boundaries, thinking about those things are important. And that kind of brings me to the end of our presentation. Let me see here. This is kind of a summary of all of the different tools that we reviewed and some of the different strategies. Please email me if you feel like you want more information, and these are the references, any more information on any of the tools I provided or any of the concepts I discussed, or like the integrated care competencies from SAMHSA. So that was kind of a big overview on communication with interdisciplinary teams, but hopefully helpful to all of you. Thank you very much.
That was a great overview, and those are all very good questions, especially the last ones you were discussing. I want to open the floor right now to hear a little bit what strategies or what tools of communication some of our learners in their respective organizations feel like they connect more from your presentation. What are the types or styles of communication that you all use at your organizations? Anyone? And I also wanted to start with Dr. Antoine. Dr. Antoine, what is your style at your workplace? What type of communication internally do you use to make healthcare more efficient and more protective for the patient?
Yeah, well, I think one of the big things, the formats that were presented, I think are a great overview of the different types. We just make sure it's regular, so routinized every week. Everyone is predictable, and they can show up and be part of that space, and give each discipline an opportunity to vocalize their viewpoint on what's going on. So the key I found is that it's regular, so everyone expects it, and it's part of the culture, rather than hoping it's that, hoping that it happens and creating more of that multidisciplinary isolated lane. We just, make sure that it's part and an expectation of what happens for the betterment of the care of the individual.
Yeah, I think that's so key. And thank you for mentioning that. The most important thing is making sure you have that consistency of bringing the team together. So even if you don't use, like you said, any of the strategies or any of the different like little tools, just the fact that you're coming together consistently every week or every day is a really important thing. I didn't talk a lot about a huddle. And so your teams may do that in the mornings. In some healthcare settings, that's very consistent. So we have kind of in our practice gone in and out of using huddles. Now we typically use more of these team meetings, but that consistency is really key in making sure everybody has the opportunity to collaborate. Thank you.
Absolutely. Anyone who wants to briefly share how they communicate in their own teams or in their own organizations? If not, we can move to the second part of the class, and I'm sure that we will revisit some of this content today, specifically with the case that we're going to be discussing. So let's move to our announcements. Karen? Thank you. And remember that the Center for Substance Use Training and Implementation CSTAT offers technical assistance. This is a great free service, kind of a personalized, very specific service that we offer to all of our participants and community members. It could be clinical mentorship, case consultation, distribution or use of medication for opioid use disorders. Any type of request or information that you need from us here at CSTAT, please go to our website, to our CSTAT website that we're sharing with you in the chat right now. And there is a request form, and someone will get back to you in approximately 2 or 3 days. So please enjoy and use this great resource that we offer you here at BeWell Texas. Next. And remember, there is a post-session survey. We are sharing it with you, but we are sending it to you after this class along with the material, the didactic material that we're sharing with you. When you answer that survey, you are going to give us your perspectives, your ideas, your opinions about our classes, and also you will be qualifying for a $30 gift card. But most importantly, remember that after that, you will be receiving your certificates or Cs in approximately 2 or 3 weeks. Thank you. Next. And we're always looking for case presenters because at ECHOS, we believe that knowledge happens in real time with real cases. So anytime that you or your organization want to discuss a case, this is the perfect space to do it. If you want to present a case with us, please send us an email at cstat@utesca.edu. Next. And BeWell Texas is still looking for participants to this incredible study that can change the future of opioid use disorders. Anyone, can be you or someone you know who is going through buprenorphine treatment, can take part of this study. There is compensations for it, and we are sharing with you the information of the person you can contact if you want to participate. Anyone who's 18 years old or older, or anyone who is, or with anyone who is in treatment for buprenorphine. Next. And we continue with our webinar, Thriving in Substance Use Disorder Service Delivery in the Post-COVID Era. Our next session is on Wednesday, July 10th. If you want to register, please go to our CSTAP website. It's completely free, and we're going to be offering CMEs and CEs. Next. And next month in this same space, we will have Didi Stout, discussing stages of changes and the trans-theoretical model. That is Friday, July 26th. Please go to our website and register for this class. Thank you. And now we can go to our case presentation. Dana, if you are ready to share your case presentation.
Yes.
And you can walk us through it briefly. Thank you.
Sorry about that. Let's get brief. Okay, so this is my case presentation. Basically, 36-year-old female, heterosexual, Caucasian descent, cultural considerations, bio father deceased from heart attack, alcohol abuse, mother with chronic COPD and THC use. And also what should be on here is a brother who had an overdose that resulted in death. Questions that I'd like you all to remember and kind of help me with. What steps would be recommended? What are identified gaps in services? How can doctors, clinicians better serve clients, patients when a new legal charge comes into play? And what strategies might be used to encourage the client patient to get back on track with mental health and recovery? Client served 1.5 years at the TDC system for drug and alcohol charges, with part of it at SafeP for rehab and substance abuse. She was released in February and she overdosed in May of the same year. The client's mother is very supportive and involved in her recovery. Mother contacted this therapist about, I'm an LPC and LCDC, about therapy services for daughter in June after the overdose. Mother still had POA of client, and client was okay with that because when she was in prison, she let her mother have POA and her mother still was kind of helping her. Client is in favor of therapy. Client set up appointments. Quetiapine and buprenorphine naloxone were started after the May overdose, and she was on parole. Client's goals were to address past trauma, learn how to feel and accept emotions, work on the recovery journey, and some of the existing strengths and resources. She's strong-willed, motivated for recovery. This time, as she had gone to treatment at least 5 to 6 times previously before the prison sentence, client attending 1 time a week, face-to-face therapy appointments, June through October. Client recognized mental health medication and MAT were important to stay clean. Client recognized the relationship in the therapeutic process is important for her to stay interested and invested. And she recognized she was in flight mode from her teen to adult years. Different interventions that were used: CBT, working with thinking errors and mindfulness skills; DBT, using techniques to utilize when emotions become too intense; the polyvagal for safety and connection, addressing the autonomic nervous system with fight, flight, freeze; and EMDR for trauma. I'm certified EMDR clinician and DBT and CBT and all those, primarily using EMDR. Therapy went downhill in October when client was served a warrant for the May overdose. Client absconded, went to live with a boyfriend. He became verbally abusive after she moved in, usually the case, right? Client started tapering off her buprenorphine and naloxone and her quetiapine before turning herself into local authorities because she knew they were not prescribed at the local jail. She was afraid of, I guess you could say, she said, going cold turkey off of these medications and didn't know how long she would be in the local jail. Client started using THC and drinking while coming off the prescriptions. Client's mental health and recovery were regressing due to new possession of the heroin charge and moving in with abusive boyfriend. Some of the history The stimulants, so she used cocaine as a teen periodically, meth as an adult just periodically. Her drug of choice was opioids, heroin, and pain pills. Nicotine as a teen cigarettes, vaping regular as an adult, alcohol as a teen and an adult with regular use and some binge drinking. THC as a teen, and I wrote regular use as an adult, but when she started on the Suboxone, she really wasn't using the THC regularly. She was doing very well in her recovery. She wasn't drinking, and it wasn't until she got a new drug charge that she started going back to THC and drinking. Opioids introduced to Oxy as a teen, and then heroin at 15 years old. Other hallucinogens, she used some LSDs, some MDMA, and some psilocybin periodically. Additional background: served a warrant in October after the May overdose. Substance use counseling, yes, present. Inpatient substance use treatment was in the past. She had done some SMART recovery, but I'm not sure where we discussed it. She was on the MOUD for Suboxone, and then nothing for the alcohol use. Additional comments: therapy went downhill in October when client was served a warrant for the May overdose. And she didn't know she had this warrant. She was doing beautiful with recovery and therapy. It wasn't until they showed up at her mother's house, and she, like I said, absconded. She left town. Client's mental health and recovery were regressing due to new possession of the heroin charge and moving in with abusive boyfriend. Therapy sessions went from one time a week, face-to-face, to intermittent telehealth. Lack of support system in a new town. Lack of support from mother when, well, she had support when she lived with her mother, but she had the lack of the support when she moved to another town. And then she had to get a new job. So she does have, she's diagnosed with bipolar and has the intermittent depression that comes on, anxiety. She has some PTSD from living in prison, and then her biological makeup with her brother dying. Her brother died, I guess, when he was in his 20s. She was like maybe 19 or 20, and she had had a conversation with him right before he died, and that was really traumatic for her. History of trauma: sexual assault from a distant uncle as a teen, bullied as a young teen for early bust development, trauma in the 20s from brother's overdose death, and trauma in her 30s from prison experience. Trauma from father's alcoholism with bipolar diagnosis, which resulted in death. She was taking the quetiapine, i.e. Seroquel, for her diagnosis, and then the buprenorphine and the naloxone for her MOUD. And anyway, against medical advice, she didn't let her doctor know when she started coming off on her own. And then this just kind of talks about some of the different, I have already mentioned in the previous, some of the types of modalities we were using in therapy. But here's the but. So I am with Hill Country MHDD, and we just started an alliance with Be Well. We are like brand new, and we are working on policy and procedure, and still I have been working with the recovery community. I was in private practice for many years. We have 20 sober living homes here where I live. So I was primarily the therapist. The confession I have to make for y'all is this client ended up overdosing and dying, which breaks my heart. She was a success story. And so any input you all have, because I know this will come up with our new programming that we're doing. The client was just a model when it was just the fact that she got a new legal charge that everything went downhill, and she just absconded and just moved in with a person who she didn't really know that well. So anything you all can offer, because we don't want to see this happen again. Happens too often.
Thank you for sharing that. Wow, that was quite a quite a shock for me, and I'm sure for all of us in the call, but we appreciate you sharing that with us. Want to open the floor right now and hear what you all have to say after this
Uh,
this
and,
case.
I'll start just by saying that I know this is a very difficult situation, having just seeing all the work you put into this individual. And I know it's not something that any of us take for granted, the work that you're doing, and also the impact of the loss. Loss of any type, especially this type, is difficult. So thank you for that work that you have done. And thank you for being open to just learning about next steps. I want to leave time for input for others, but I just wanted to leave with that all the work and effort and emotion that you put into this, it really does show.
Yeah, I want to second that as well. Thank that. And the work obviously that the client put in. And it just infuriates me that the legal system comes along and just pokes the big hole and rips it apart with no thought of what they just did. Instead of, and part of what we talked about earlier, we faculty here, is perhaps would there be a way to consider having the case transferred to an area that has a drug court that might be more understanding about things like she should have had Narcan when she left, because we know that people use when they leave prison, that is the most vulnerable time for overdosing, for prisoners coming right out. Things like, can she stay on the Seroquel and on the Suboxone when she's in, if she does go back to prison? Let's at least keep her on the medications that keep her stable while she's in prison. So that's good for everybody. And it continues her treatment, so she doesn't go backwards in that sense. It makes me nauseous.
Our local jail does not give it, because I've had too many people in recovery that, like, maybe they're on gabapentin or they're on like the bipolar meds and they do not give it. It's one of those that maybe with our new program we can work together, because her mother did have POA and her mother has signed a ROI for me to tell her story. I mean, obviously I'm not going to use her name, but to tell her story and to use it as an example. So yeah.
Great.
So
because you're right. This is a typical case, sadly.
Heartbreaking, but I also would like to very briefly acknowledge all the effort and all the attention that you put into this person. And it shows that it was something that you really poured your heart on. And this was someone that you really care for. Who else wants to add something to the conversation? Dr. Antoine, you were going to say something.
I was going to say that this really goes back to the lecture that we heard, and that transdisciplinary and also interdisciplinary is important. One discipline that we could utilize over time would be the legal system, the justice system. I had a situation where we didn't know about some of the legal charges until a few months in. And there could be an opportunity to utilize that at the beginning and incorporating that into maybe some of the treatment goals as to identifying potential barriers or challenges on the legal side, and proactively reaching out to any parole or justice agents to try to head that off at the pass as well. It's often a very frustrating disruption that can occur.
Anyone in our call, I'm sure that some of you have something to say about this case, similar situations, ways in which things could have been handled in a different way. Dr. Aguilar, what do you think?
Yeah, I'm kind of sitting in reflection, Dana, about how compelling the story is, and also just thinking about it like from a team perspective, the idea that you kind of brought this to this community. I want to thank you for your ability to talk about something that I'm sure has been so challenging for you and your team. But I think it's very helpful to hear the impact, or for us to feel the impact. I mean, it's helpful, but not comfortable. But oftentimes that's where we need to be for change to occur, is in this place of thinking, okay, what could we do differently? As Dee Dee was saying earlier, one of the things we were wondering, and I really don't know if she could ever get transferred, but in San Antonio and Bexar County, we do have a drug court system, a system where if a patient were, or if an individual were seen in drug court by acknowledging that they have a substance use disorder, they might get channeled or funneled into treatment rather than into a forensic setting. And I don't think that it doesn't sound like that exists where you are, and I don't know if that would be possible, but it is those sorts of initiatives that could be helpful and to help people kind of think about how to set that system up. I know our Bexar County system is always having discussions and presentations locally, but perhaps, you know, that kind of needs to get spread to other local counties so that other local counties and leadership there can take on those sorts of initiatives. I know I see Miss Lena with her.
Yes, Lena. I think you're muted. Can you unmute yourself, Lena? We cannot hear you.
Maybe you can put it into the chat, Lena. Yeah, it seems like there's something wrong with the microphone.
Yeah, she's having technical difficulties, but she can add it to the chat if she wants to, and we can discuss. So, Lena,
I'm curious if you think you can use this as, at the very least, an educational tool for meeting with the court system wherever you are and presenting this not in a way of, you know, obviously blaming, but of saying, could we have a conversation about this? And, you know, where this young lady was, the work that she had done seems to have kind of gotten missed. And then she got off track mostly by the warrant that was served, and, you know, using this as an opportunity to see what could be done differently. Do you think they would be open to that?
Yes, ironically, I used to be a probation officer here, and I've written many letters as a therapist to the probation officers when they're on probation. This was different because she was on parole, and we are Kerr County. She was on parole out of Bexar County, to Dr. Aguilar's. She was on parole, but her charge was in Kerr County, and Kerr County doesn't work real well with her. So her parole was in Bexar, but her charge was here. And yeah, it's just very convoluted. I tried, you know, there was so much more to it. I tried to tell her I could write a note to the court, but of course I don't know that the court's going to take it. I also know that parole's different than probation, you know what I mean? And there were just so many, but I have brought up to our 216th district court, our judge, about this and our new program, because we are just brand new on the medication assisted treatment. And I said, you know, I would like to do a talk with their staff and kind of use this. And he said that we had a drug court, but none of us here knows about that. Like, I don't even know. I'm like, we have a drug court? Where? And so that is actually emails that were going on earlier today about where's the drug court? Who do we talk to? Because I guess people, again, are still getting charges that have mental health and, you know, dual diagnosis. So anyway.
Well, it's great that you're
Thank
working
you.
with a team and part of this team now. So you're not alone.
Yeah. Thank you.
Certainly not. And thank you again, Dana, for sharing that experience with us. Dr. Antoine, could you give us a brief summary, specifically focusing on the case and aspects on the case where you think that things could have been done differently? Thank you.
Yeah, so thanks again for the presentation, and I think that the case is a great opportunity for thinking about team and thinking about conversations, opportunities for conversations. Obviously, it was a very complex case from different dimensions, whether it's the biological, the trauma, substance use, mental health, and ultimately we are looking at the ultimate outcome we try to avoid, but there do seem to be opportunities to ensure that we have as wide a conversation with the team, including the justice system when possible, and when open, and then making sure that there's regular conversations with providers if it is known that there's going to be a disruption. So it may be changing medications to something more long acting, injectable medications are possible, and just talking with the individual to say, is there anything we're missing that could make you more comfortable in whatever disruptions that might occur? But also, I would just put out to the team, making sure there's support where there are not the outcomes that we hope there to be, because this is a very emotional and very difficult thing that we're trying to do always. And it's really good to support ourselves in addition to the persons that we're trying to support. So in these types of outcomes, making sure there's support for the team as well. We have a RISE team that can help with these types of outcomes, which looks at the secondary trauma that comes for the practitioners. Now, I'd put that out there as another opportunity as well, beyond the great work that's been done so far. So we can talk about this, and I hope we do talk about this more in future sessions. But there's a lot of great things that have been done, and a lot of things we can take away from this as well. So leave it there.
Oh, thank you, Dr. Antoine, and to all of you, thank you again for being here today. Remember to answer your post-session survey, and we'll see you next month. Thank you.